We shall have Dr. Grewal presenting on the Zoom on a very important topic for all of us, Beyond Biometry, a complete toolbox for premium IOLs.
Good morning, everyone. And I thank Nethradhama and Sri Ganesh for letting me in for this great meeting, which unfortunately I had to miss because of the cancellations of flight and tensions in this area. Things are fine now, so let's go ahead with Beyond Biometry, complete toolbox for premium IOL. Now the best tools lower the barriers, best tools will give you the best results, and for any surgeon, one of the greatest moments of satisfaction or happiness is this few moments at the end of the surgery. But remember, the journey to this point is a long one. My thesis was changes in the corneal astigmatism after cataract surgery with a limbal-based flap, a gutter incision, 3 to 5 pre-placed sutures, intracapsular cataract extraction, and I had to do the drawings with a compass scale and a D to calculate the vector and how it is. It was 80 silk, no IOL, and thick glasses, and the only tool available was the Jewel Short keratometer at that time. Early 80s saw a big change, beginning of the IOL era, a revolution, and at that time, most of the advanced centers had just A-scan biometry. With the changing times, the objectives have shifted to a safer surgery, better visual rehabilitation, shorter recovery time, greater range of vision, objective of emmetropia for both near and distance, and we have now younger and professionals coming to us for surgery, and as you all know, premium lenses are more demanding for the surgeon. The changing times have also led to new techniques and new tools. Understanding the factors which affect the IOL calculations and tools to accurately evaluate these factors. Then we are looking at factors affecting quality of the vision and tools to accurately evaluate these factors. The use of AI to improve the formulae, complete examination of the eye beyond biometry, which is gaining more emphasis these days, and a greater attention to evaluation of the retina to predict the results. Let's first scratch the surface, that is the tear film. It's a common cause of dissatisfaction after premium implantation, can start or can be worsening of the pre-existing condition, and we know that worsening occurs due to the screen use and especially with premium IOLs. So it's important to document and test the signs of dry eye syndrome before the surgery, both for prediction, deciding for the premium lens, and also managing it before we do the surgery to these patients. So we know that it can have a cascading effect on the surgery. It can affect the preoperative keratometry, topography, wavefront imaging, and the intraocular lens power calculations. That preoperative dry eye evaluation helps predict chronic dry eye development in patients undergoing surgery, and detection and treatment of dry eye prior to surgery is always the optimal path for a premium cataract surgery and enhances patient satisfaction. How does it affect the accuracy of the biometry? It can affect both calculations of the spherical component as well as the cylindrical component, beautifully described by Alice. And also it shows that the changes both in anterior K can take place if the ocular surface is not proper. These are the optics showing on a good surface, and this is if there is an irregular surface or dry eyes. Since the rays going inside the eye and coming out are not properly focused, it affects the use of our instruments and therefore doesn't give a very accurate reading. The role of the tear film on the optical quality has been well studied, and this study shows that with the drying up of the tear film, there is a huge difference coming up in the high order aberrations. We have the dry eye score, both the speed questionnaire and the OSDI questionnaire built into the software and the EMR, so that each patient we have the OSDI done for these premium lenses, so it gets documented also. These lens cases should have a complete dry up dry eyes workup as part of the work of these cases. This is the tear film breakup time. Then myography is important. As you can see, if there is an issue, you can go ahead with LipiFlow. You can see the dropout in the meibomian glands in these cases. If you see the pre and post-op, you will see that there is no difference in the myography in these cases, but they definitely lead to improvement in the OSDI scores. So we must initiate the treatment for dry eyes after making the diagnosis and perform preoperative biometry only once the patient's symptoms and signs have resolved. Angle kappa is the difference between pupillary and visual axis. Everybody knows it. There are good number of machines which can do it. Even AutoRef can do it. But it's important to note the angle kappa in every case, because if the angle kappa is higher, the patients with multifocal lenses will have a greater chance of glare and halos. Now, as in this study, you can see that with the change in the angle kappa, what is the effect? Now, interesting observation is, if you see these three graphs on these three different angle kappas, you see it doesn't affect the spectacle independence. But if you see the halos and the glare, you will see that greater the angle kappa, greater are the dysphotopsia to these patients. That is why it's important that these multifocal lenses should have consideration given to angle kappa. A 0.3 mm or less, low risk of IOL decentration and dissatisfaction. 0.4, increased risk. 0.5, you may consider as a cutoff value, but final cutoff value that you will decide will also be depending on the specific type of the lens, the surgeon experience, and the individual patient factors. The next important evaluation is the retina evaluation. If patient has any pathology, please refer the patient to your retina surgeon or colleague and have a clearance for surgery. And there may be situations where the management by retina surgeon is important, like cases with cystal macular edema. Always perform as an OCT macula to rule out any posterior segment pathology. That is the standard protocol we have been following for many years. And surprisingly, in cases which look everything fine, fundus picture looks okay, you will see they have a lamellar macular hole, or they have PFT, you will pick up, or they had a thinning of the retina due to a past vascular occlusion. So doing OCT and studying that and analyzing is crucial. Diabetic patient must go to retina surgeon, have the pre-surgery treatment and a plan for post-op management. Similarly are the cases with age-related macular degeneration. If these cases need treatment or injection, that should be done by your retina colleague before you take up for the surgery. Another important thing is the correlation of the extent of cataract to the visual acuity. Now, this is a case which didn't have improvement in vision, and the patient had ethambutol toxicity. So whenever the extent of the cataract doesn't correlate, please pause and see what is happening. Patients, you may have patients with both the central and peripheral pathologies like glaucoma and ERM. This is again a patient which will have compromised results. Another evaluation that you have to see in these cases with premium lenses is the quality of the cornea, because that is where the maximum refraction is taking place. And do look for the high order aberrations in the central 4 mm zone. And if the value of the high order is higher, then please don't select these cases for multifocal or trifocal lenses. A potential visual acuity meter is again a very simple and a good tool to assess that what is the potential of the vision in these cases, that the patient with ethambutol toxicity could have been picked up comfortably, easily with a potential acuity meter. The posterior corneal curvature is gaining now more and more importance, and it deserves, with the total keratometry coming, it deserves due diligence and due role to be given to it. B scan in white cataract should be mandatory in all cases with white cataract. The question is, will you do premium lenses if a patient comes with white cataract because you can't see the retina? What we do is we do the biometry for both the eyes at the first eye testing of the patient, even if the other eye has no cataract, because earlier there were many patients coming second time, they had come with white cataract. And if you have your old record, it helps you a lot in getting the accurate power of these lenses. We are all aware of the photopic phenomenon, the glare, halo, dysphotopsia, and for these, please set expectations for rings, glare, and starburst. And for this, it is important to give a proper shared time to the patient, do a proper counseling to them, and it's also important that the personality of the patient also is important, as has been mentioned by the previous speaker also. And there is a study which shows that personality traits such as low conscientiousness and extroversion and high neuroticism significantly influenced quality of vision perception 6 months after bilateral multifocal lens implantation. So patient personality questionnaire could be useful preoperative assessment test for these multifocal IOLs, and these personalities will definitely need more counseling time, and preferably the time given by the surgeon himself. So we aim to have maximizing diagnostic accuracy. I'll call it a multimodal evaluation of the eye before cataract surgery. We have so many tools. We have IOL Master, we have Lens Star, you have Cyrus, you have OCT, you have B-scan for that, you have the cataract workflow, you need a good fundus camera, you need a pentacam, you need iStar, so you need the Callisto, or so there is lot of armamentarium which is now available with us to look at the eye completely and make a better choice for the patient. And then you have the cataract workflow, which is again an excellent thing, which makes things a lot easier, faster, and accurate for you. So to reach this is a long journey, but it's worth the fun and the pleasure and the enjoyment you get doing good surgery. The story ends here, but starts with a thorough and complete workup and decision making. Thank you so much.
Thank you, Dr. Grewal. Thank you for unpacking the complexities beyond standard biometry with such clarity. Your comprehensive take on optimizing premium IOL outcomes added immense practical value to our learning.